us who have joined us here on Zoom. We are happy to host this evening our first in a series of Surgical 101, where instead of just discussing topics in endometriosis, we're actually going to take a look at surgical technique and debate a little bit on what's best for how to do excision. Please welcome this evening, along with our Endometriosis Summit co-founder, Dr. Andrea Vidali. Please welcome Dr. Gaby Moawad. Dr. Moawad, do you want to go ahead and introduce yourself? Thank you for joining us this evening.
Of course, thank you for having me. It's a great pleasure. My name is Gaby Moawad. I'm an associate professor at GW, but now recently I founded my own practice, which focuses on endometriosis and advanced pelvic surgery in the Washington, D.C. area. So tonight, I am super honored to talk about bowel endometriosis and different surgical approaches. I think this is a very important topic, especially empowering our patients to choose their surgeon and understand what question do they want to ask them before they proceed with surgery. So,
now, I want to let everybody out there who's watching, I want to let you know that demonstrating surgery was actually Dr. Moawad's idea. He was in a panel in the World Robotics Symposium, and he said, let's embrace the wave of the future. Let's stop having it be about big, expensive conferences that you have to attend in person, of which I host one of those, but we're not so expensive. And let's use technology to truly educate. So the minute he said that, Dr. Vidali and I were like, oh, we have to have Dr. Moawad right now, because you're right. It's our turn to educate the endometriosis community, both surgeons and patients, on how to move forward in their lives to help with endometriosis.
No, I completely agree. This is very important. It's not about us as surgeons. It's more about the patients. All what we can do is we put a smorgasbord for our patients about the different approaches, and it's for the patient to choose. We will help her with the science, with the technique that we perform, but at the end of the day, it's her choice, her opinion, their choice.
Their choice. That is excellent. So tell us, you guys, what are some of the symptoms of bowel endometriosis?
So bowel endometriosis, and actually this is kind of one of the main complaints that patients, when they come and see you, all of them think they have irritable bowel disease, because this is what they were told by their general OBGYN. Like sometimes you have more diarrhea during your period, sometimes you have more constipation during your period, in addition to the classic symptoms of infertility, pain during bowel movement, bleeding during bowel movements, pain during the period, pain during intercourse. It's a complex, wide variety of symptoms. And in addition to bloating, nausea, all the non-specific symptoms. But I believe mostly there is the diagnosis of irritable bowel syndrome is very loosely used for patients with endometriosis. Once you start digging in, and those patients have multiple colonoscopies, they saw multiple GI doctors, and they say like, oh, everything is normal, or, you know, take more fibers, take less fibers, take a laxative. But eventually when you dig into the questionnaire, you realize that this is bowel endometriosis typically.
Gaby, that's a very good point you said, and I think we need to maybe expand on the fact that more often than not, even when there is significant rectal endometriosis, the colonoscopy, and there's rectal bleeding, the colonoscopy is negative. Do you want to expand on that concept? Because we see that all the time, right?
Yeah, and it's the same thing with a lot of specialty that are not trained with endometriosis, because the colorectal, the GI doctor who is not trained to identify the lesions of endometriosis in the mucosa when they do colonoscopy, they think it's normal. They think this is nothing. They could eventually figure out the powder burn, but most of the lesions of the mucosa are hyperemic or a lot of vascularity, redness, inflammatory lesions. And then many GI tell the patient you have Crohn's maybe, or let's do a biopsy and it comes back inconsistent or incomplete. So I think the training of them identifying these lesions are key.
And also sometimes the lesions can be submucosal.
Yes,
which are not, actually most of them will be submucosal,
Yep.
great majority, more than 90%. And, but they can still cause bleeding. That's the thing, I think the bleeding is caused by disturbed vascularity, inflammation. But, when you actually look at the mucosa, probably, I mean, the lesion, the endo may be a couple of millimeters above it, but, there's no actual, lesion to be seen. That's just, in a way. Of course, the patient gets told that the colonoscopy is normal.
And I think they need to be guided by the referring physician. So if I refer a patient for a colonoscopy, I need to tell the GI what should they look for. So in addition to endometriosis lesion, I'm going to tell them, do they have any masses that are compressing the rectum? Do you have any kinking in the rectum or any abnormal path of the rectum, stenosis of the rectum? They need to understand those because many times they think, oh, this is the uterus compressing on the bowel. That's why it looks like a mass. And you say, no, this is not the uterus. So guiding the referral, if you refer a patient for an MRI, if you don't tell the radiologist what to look for, they come back and tell you she has uterus, 2 ovaries, and everything looks normal. You need to guide the referring physician.
So one of the overall themes that was going on at this year's endometriosis summit was that people were very angry at that their radiologist missed something, right? Mm-hmm. There was actually there were a couple panels that people were standing up really with the microphones and, this person missed this and this person missed that. And Andrea was very clear in stressing, you have to work on that imaging with your physician, but you have to take that imaging to the specialist directly.
Yep.
Yeah.
Oh, this is very important because we published a paper about the specific protocols for endometriosis yield. If you send a patient for pelvic MRI and then you do not have a protocol for endometriosis, most of the time, the regular radiologists do fixed cuts and do skips between lesions. So the MRI for fibroid is completely different from the MRI from endometriosis, and the MRI for compression of nerves with endometriosis is very different from a regular deeply infiltrative endometriosis MRI. So it's our job and obligation as specialists in endometriosis to sit down with the radiologist and establish a protocol on the thickness of the slices, the skip lesion, which T1 fat saturated, T2 fat saturated. So we need to make them understand what we look for. And then the most important thing that I find is I go back to the radiologist whenever they miss lesion with surgical videos. And I tell him, this is where the lesion is. Can you look at it at the MRI again? And he said, yeah, probably I would not read it. Yeah, now I read it like this. So it's a continuous education between us educating ourselves how to read radiology and the radiologists educating them about the different protocols, the sensitivity, because at the end of the day, if you don't guide them, all the MRI is going to be normal.
The other part of it, sorry, Sally, please.
Go ahead.
The other part of it is in my experience, if you send a patient to an MRI center and the diagnosis is endometriosis, they think, oh, this is not serious. Let's put the patient in our 20-year-old machine, which is basically, no better than an ultrasound. Yeah. Well, they have maybe a much more advanced, so they'll stick her in a Tesla 1.5 where, it looks like, when I was watching soccer games in the 70s, you understand that, with the play, and as opposed to a really good quality machine. So that's another problem that I think they have a bias that if you send somebody for, rule out pancreatic CA, they'll put them in the good machine. But then, so stuff that they don't think it's important enough, they will, unless they know you as a referrer. Like, for example, there are certain centers where I send, they know me already. And so they'll say, okay, no, this is serious. But that's another problem that I see. People that go outside in random MRI centers, which have like, you know, very, very low quality machines, very low quality images.
Yes, so since tonight is Surgical 101, I wonder, Dr. Moawad, do you have, say, a presentation to share with us?
Of course. Did you think I would come unprepared?
Well, you're the most prepared. We've been doing this for a year. This is the most prepared anyone has been.
I'm going to share my screen and I'll go over that stuff with you guys. So I wanted to talk today, like the whole purpose of my talk is to review the colorectal endometriosis and talk about the surgical strategies for endometriosis. A few important things, like we have to know that colorectal endometriosis is very frequent. It's not a rare disease. It could be a rare disease for the ignorant people who cannot detect it, but it's really, really common, 5 to 12% of patients. Now we like to call it more posterior compartment endometriosis. And if you can see on my slide, the posterior compartment is with yellow, that mostly the uterosacral, the bowel. And when we say rectovaginal endometriosis, this is most likely a misnomer. This is not true, because most of the endometriosis between the rectum and the back of the uterus, infiltrating sometimes a little bit the vagina, but not deeply infiltrating the rectovaginal septum, except in advanced cases or low lesions. So most of the rectovaginal that we call is a little bit higher than the rectovaginal septum. So this is what it looks like. You would think like this is, you could burn it for the ablation people. They could burn the bowel with it. But I'll show you the video of specific that case, how aggressive is it infiltrating the muscle of the bowel. We talked about the symptoms, pain during bowel movement, different GI disturbances, constipation, diarrhea more during the period, pain during sex, pain during the period, pelvic pain in general. So here we were talking about the MRI, and this is the protocol that we published in Fertility and Sterility to tell you that was back when we had 1.5 Tesla. Now we use 3 Tesla. So we do in regular standard protocols, they do 8 millimeters with a skip lesion of 2. So you could miss easily between 1 and 1.5 centimeter nodule on those stuff. Now we go down, and nowadays I do 1.5 millimeters slices, which have a high yield even in the nerve stuff. So it's very important to have a protocol for endometriosis if you want to do advanced endometriosis surgery. This is the most important thing. It's a multidisciplinary approach to all those advanced endometriosis. So that means it's not one surgeon, it's not one specialty. And that is sometimes a little bit mistaken for some patients, because many surgeons who do not prep the patient before time, they end up calling a colorectal intraoperatively, and that colorectal might not have any experience with endometriosis, or maybe a urologist. So having multidisciplinary approach is more, there should be more emphasis on the team. So every surgeon should choose their team so they can train together, they can advance their skill together, they understand the way each other works. And this is how we optimize the value of care that we give to our patients. So we cannot rely on a random surgeon jumping in and saying like, oh, let's open this patient, or let's do a colostomy where it's not indicated. So it's very important having a team rather than multiple specialties, a team of multiple specialties. So the philosophy for surgical approach, the most important thing is we have to optimize a plan before surgery. When we do surgery, we go and execute. The plan is made before surgery. Now, there's always variation of the plan in surgery, but when you become an expert in preparing, then the variation would be minimal in surgery, you know, ahead of time. The other important thing, this is not cancer. And most of colorectal surgeons who do not have any experience with endometriosis, they treat it as a 90-year-old patient with terminal cancer of the bowel. This is not cancer. Our patients are younger, healthier, so we need to make sure that we give them the appropriate treatment rather than a radical and unnecessary treatment. The bowel endometriosis have very minimal complications in the right hand, but unfortunately, those complications are serious. So I'm gonna talk about we have two recent meta-analyses. One of them is already published and the other one is accepted. And this is very important because I have a lot of patients that are coming thinking they have a problem with the bladder or endometriosis with the bladder, rather their nerves feeding the bladder are taken with colorectal endometriosis. So when we do the surgery, there should be, the surgeon should have very advanced knowledge of anatomy and nerve anatomy to be able to spare those nerves, like when they do for-man prostate surgery. If they don't do nerve-sparing prostate surgery, these men will have a lot of issues. So for us, with the three techniques that we use, disc excision, segmental bowel resection, and shaving, shaving is the safest in terms of less bladder complication after surgery. And some of the patients, if we damage their nerves or endometriosis already damaged their nerve, they could end up having self-intermittent catheterization for life. So advanced knowledge, because for a patient to self-catheterize for life is more shaming than if she has pain, self-shaming. So we want to have a serious conversation with a patient ahead of time so they can understand their option. And then everyone would choose to have a residual pain rather than have to self-catheterize for life. Again, this is the other meta-analysis that will come soon, also in JMIG. And then we reviewed all the literature about shaving, disc excision, and bowel resection in terms of leaks and fistulas. Shaving has less risk. Disc excision has similar risk as bowel resection, but the advantage of disc excision over bowel resection is maintaining the bowel function. Because if the lesions are really low and we do a segmental resection, we end up taking the nerves feeding the bowel. So what happened, patients would have what we call a low anterior resection syndrome. They have frequent diarrhea for the life and they have many other problems. So it's very important to have those conversations ahead of time with patients and choose what is the appropriate option for them and for their condition. So here are our strategies: shaving, disc excision, and segmental resection. And I'm going to explain each one, what does it mean. So there are indications for each and every one. And the indication, depending on the lesion, the lesion size, how many lesions do you have, how much the lesion is taking the bowel circumference, the size of the lesion. But at the end of the day, in expert hands, you can understand that these are not carved in stone. There could be variation. Some surgeon could remove more conservatively larger lesions than others, but it's very important to understand all those metrics before surgery so you can make a plan, you can counsel your patient appropriately. So this is the multiple sites of risk injury when we do colorectal endometriosis. We could injure the nerves feeding the bladder when dissecting the ureter, the nerves, the parasympathetic nerves and the sympathetic nerves feeding the bowel. The inferior hypogastric plexus is very important, and then it has 3 branches. And sometimes the 3 branches, one for the bladder, one for the rectosigmoid rectum, and one for the vagina. So many times, pain, persistent pain during intercourse, after surgery, which is commonly thought as, you know, maybe within treatment of endometriosis, could be from a nerve damage of the branch feeding the vagina. So that's why nerves are very, very important, and surgical knowledge of the pelvic nerves is very important to recovery and understanding those potential complications. So here I'm going to show you a little video This is a posterior compartment endometriosis. This is the bowel. What we do is we try to go to an avascular space close to the bowel. It's called the pararectal. Now here I identified that little band that you saw. This is the hypogastric nerve. So I stick closer to the bowel, and that freaks out like novice surgeons or surgeons with no experience to come closer to the bowel. But with experience, you have to stick to the bowel to spare the nerve. Be close to the bowel in your surgical technique. So we open those spaces that we call pararectal on each side of the bowel to isolate the lesion that is attached and scarred. And you're gonna see that once we open those spaces do not contain anything important. So these are avascular. So you can see there's not much bleeding going on, even though I'm pushing tissue. So now here we can see this is the endometriosis. So now we isolated the bowel from each side. The nerves are lateral. And now I'm gonna cut the nodule in two. So this is the next, is transect that nodule in two. And I'll tell you what happens many times with surgeons who do not do excision surgery or who don't do endometriosis surgery. What happened, they transect that nodule or they do a lysis of adhesion and they leave the disease. They think that was because of endometriosis and I did the dissection. Here you can see a little bit the chocolate from the endometriosis or the old blood. So all what we're doing, we're cutting the nodule now in half. We're not cutting the bowel, we're cutting the nodule. So we push the fat that belongs to the rectum. This is the vagina here. And then when I separate the rectum from the posterior aspect of the vagina and the uterus, what I am left with two things. I am left with the bowel portion of endometriosis, which is here, and the vaginal portion of endometriosis. So both of these need to be excised to ensure excision of complete disease. So now this is the bowel disc, and this is the vaginal disc that I will be pointing that needs to be excised. So we'll continue. What does shaving mean? This is the bowel wall. The bowel wall has a serosa, which is the outer layer, has a muscle, and has a mucosa, which is the inner layer. Endometriosis starts from the outside and penetrates to the inside. In contrary to colorectal cancer, starts from the insides and go to the outside. So shaving means removal of any one of those layers. So there is superficial shaving when the lesions are on the serosa. There is deep shaving that goes through the muscle. And there is the disc excision is when you take a portion of the wall of the bowel, enter the lumen of the bowel. So these are the differences between shaving, deep shaving, and disc excision. So here I'm going to show you a small video. What do we mean that we have a disc excision? That looks like a small powder burn. That could mean for some surgeons, like I could burn it judiciously and it's done. So what I'm doing here, I'm putting a stitch on that endometriosis nodule and I'm elevating it. I have in the rectum a little dilator or a little sizer that will enable me to see the rectum. So now you're gonna see that little powder burn. How big is that disc? So I'm removing all the fibrosis from the bowel wall through the serosa, which is the outer layer, the muscle of the bowel, and then I'm gonna spare only the thin layer or the mucosa. So we wanna make sure that all the fibrosis is out, which is the inflammation and the scarring from endometriosis, and what do we have remaining is soft tissue. So now when I touch, I feel those tissue are soft. You can see the fibrosis and the thickness And I'm gonna remove all that. And then you're gonna see that small pinpoint of endometriosis that everybody would think this is only a little bit of endometriosis, ends up being like a 1.5, 2 centimeter disc that we shaved. I'm gonna advance that a little bit, you can see. And now you can see here, after we remove it completely, you're gonna see how much muscle we took and what's the defect that was there where you thought it's a pinpoint chocolate lesion, ends up like I'm here, I'm approximating the muscle with a stitch of the bowel. And the value of preoperative imaging, having a plan before surgery, enable you to do a minimally invasive surgery, and this patient went home the same day. So this patient we spared, you have a thin layer, which is the inner layer or the mucosa. We shaved the whole muscle as deep shaving. So this is the value of preparation, understanding the disease, excising completely the disease, and enabling the patient a better outcome. I'm gonna move to the disc excision. You can do the disc excision the way I did the surgery for the shaving before, but you enter the bowel lumen, or we use sometimes what we call a circular stapler, where we take, this is from the side of the bowel, we take that disc inside the circular stapler and we remove it. And here you can see the different steps, and at the end you excise the endometriosis, you remain with a staple line with no endometriosis, like here. So endometriosis is here, you push that here, you take the stapler and take only the anterior portion, and then you end up with a staple line at the end. So I'm gonna show you a video about that. So here we take portion of the disc distally with a suture, and we take the proximal portion of the disc, and then we advance the circular stapler through the vagina, through the rectum, and we push that disc inside the circular stapler. Eventually you can do that manually with the scissors and close it. So now this is the circular stapler coming in transrectally. My colorectal is doing that, and I push the disc down in between those two portions, and the colorectal surgeon would fire and then would end up taking portion of the disc. So this was a double disc excision. We repeated the same maneuver so we can remove the whole endometriosis disc, because it would not fit in one, and we want to salvage the patient a bowel resection. So you can see now the edges are softer, not like before, so the disease is completely removed. We fire two circular stapler, and now the bowel is free of endometriosis.
I'd like to give credit to Dr. Harry Rich, who really was the first one to actually, one of the first ones to actually do this stuff, you know. I remember, like, you know, we were showing this stuff in 1997, and you can imagine how crazy where people were going when we were showing videos. So it's incredible. We have to give credit to Harry for really,
most definitely,
work, you know, very much. You know, he's
the
got
father of laparoscopy.
He deserves the credit for this. He really does. Sorry for the interruption, but I want
No, not at all. Please, I want to make it more interactive. And this is the segmental resection when we remove a piece of the bowel, a segment of the bowel. So what we do is we place this device called anvil. We transect the bowel with endometriosis, and then we connect them. And then at the end, you'll have a staple line that with all the endometriosis excised. And this is the more radical approach. We use it more for larger discs, for patients who have multifocal disease, different portion on the bowel, have occlusive or subocclusive endometriosis, which is when the endometriosis compresses the complete lumen and close it, narrow it or close it. So this is the surgical approach for bowel resection. Now it's a more radical approach. This is credit to Dr. Vidali. He likes those cool stuff. Green ureters lighted for safety. And here we're separating the bowel. And then we're taking out a segment of the bowel. Now here we get the distal portion. Take it out. And then the proximal portion with the disease here, which was an occlusive disease. Place that device that we call anvil in the proximal portion. And then connect those to have a full bowel resection. And now we connect those so we can have an anastomosis and put back the bowel together. That's eventually the more radical approach. And you can see here the lighted ureters in green. And then we're doing the test to make sure that the bowel integrity is intact. So this is all the stuff that I wanted to talk about. A little different technique that we use for colorectal. For patients, it's more important to ask their surgeon about their multidisciplinary team to understand which option they're gonna attempt, to understand the risk and the complication rate for each option. And that's the most valuable thing for our patients, is to empower them through knowledge. I'll stop sharing.
Wonderful. So I'm just trying to answer it. We have a question from another surgeon. Props to the MIGS group who have surgeons here tonight. And the question is, do you think it's worthwhile to do a disc excision or shaving in someone who you incidentally find out has bowel endometriosis?
Well, this comes far ahead of time, because I think the incidence of finding bowel endometriosis that requires a disc excision is extremely rare if you follow all those rules. So even sometimes if the MRI is negative and if you didn't see anything and you know the MRI was poor quality, I would prep the colorectal surgeon ahead of time, and I would prep any patients with bowel symptoms in the office for potential disc excision. Now, it happens sometimes, we are surprised. I think, you know, doing a segmental resection or a disc excision or more aggressive stuff without the knowledge of the patient and the risk could potentially be inappropriate for the patient. And then I believe many times that if we had those situations, like one time they called me to the emergency at 3 a.m. for what they think was a ruptured cyst, and it turned to be a stage 4 endo with a ruptured endometrioma. So I did not want to do anything crazy for the patient without even talking to the patient. So you do whatever you can for the patient and you counsel her appropriately, you prep your team, and then this way I believe it's a better approach for the patients if it is a complete surprise. And that's my philosophy.
Right, exactly. Go ahead, Dr. Vidali.
No, just a couple of, first of all, thank you for the fantastic presentation, Gaby. Very fantastic, really great. And I agree with you 100%. You know, I know that there are some centers in Europe that are, you know, very gung-ho at doing segmental resections. They do so many of them. And my personal opinion, you know, and I'm not going to mention any names, is that they do way too many. Especially when, and you, I don't know if you want to comment, but you know, certainly we just had a couple of randomized trials, especially from Horace back in Belgium, where they showed that pretty much when you did a shaving versus segmental, ultimately, actually, the outcome was actually probably better, I would argue, in the non-segmental group. You know, so I would say that, and that's pretty. You know, that was a great series of like 60 cases with 30 on each arm. And the other study was the same group, you know, from Leuven, actually separate group, but also, you know, same area, and 5-year follow-up, pretty much same rate of complication, segmental, and so why do the more aggressive surgery? And I have to say, at least in my personal clinical experience, I do very few segmental because I'm very comfortable with just cutting the nodule out and then fixing the bowel.
Yes,
That's, you know, like, you know.
I completely agree with you. And this is, for us, the most important thing that we do is the patient outcome. If the patient does not have, this is not cancer. We're not trying to save her life by removing endometriosis. We're trying to improve her quality of life. So we don't want to improve her quality of life with pain and incur to her a newer problem that impacts her quality of life. So I go.
There are extreme cases, though. Like I have to
Yes.
say, this is a generalization because
Yes.
we have all seen extreme cases with people who require permanent colostomies, urinary diversions, where, you know, there are forms of endometriosis that are like cancer. So
Yes.
I would like to say very clearly that yes, it's not cancer up to a point, because we do see very severe, at least you and I and a few other doctors see crazy cases where people are, you know, the disease.
It's interesting to me, Dr. Moawad, as a pelvic physical therapist, I see that patient all the time who's been to, say, a really, really aggressive surgeon because they had bowel pain, but now they have vagina pain that I could work on as a pelvic PT, or they have burning. We fixed the hernia, we've done the injection, we've done pelvic PT for a year, and yet that lower segmental nerve that's so close to the bowel, the surgeon was so aggressive, we wonder what went on. So it was fascinating for me to see that. And also Dr. Vidali talks about how, you know, the entire bowel itself has these tiny little nerves that go to it, and when you go all the way through, sometimes to strip it or to get to it, you're damaging that. What does a patient do that's had that happen?
No, so it's a combination of, you know, we try to treat their pain with gabapentin or any of those nerve problems, but I believe the key is to spare those nerves and have a very good knowledge of anatomy. Because I see a lot of, you know, misunderstanding among physicians about the nerve pain. Like for me, let's say, and I'm sure Andrea have those. For me, pain during urination. If a patient have pain during urination during her period, which is again most commonly labeled as interstitial cystitis, which is not true, with colorectal endometriosis, that is a sign of severe parametrial and colorectal endometriosis. There is taken the nerves from the inferior hypogastric plexus that goes to the bladder. So in the clinic, you can tell from only history and physical exam, you can tell a lot about the distribution of the disease and the location of the disease, rather than labeling a lot of patients under the categories of pelvic pain, like we're vomiting a chapter from a book. Endometriosis comes with interstitial cystitis, with irritable bowel syndrome, with you know, fibromyalgia. No. There are different things now that we understand in the science that tells us more beyond those general diagnoses, that why a patient that have irritable bowel syndrome for 20 years, when she have appropriate excision surgery, it's gone. Irritable bowel syndrome should be a functional disease of the bowel, should not like vanish after surgery.
Yeah, we have tons of questions coming in. I have one that's a little bit easier for Dr. Vidali. Dr. Vidali, we have a question that came in from Facebook over the weekend. Why does bowel endometriosis contribute to fertility issues? You have to unmute. Unmute.
Muting because, you know, Elvina on the other side was like running. You know, I would like to say that bowel endometriosis is usually a manifestation of significant advanced disease. And as we know, endometriosis is an inflammatory condition, and it's the inflammatory component that affects fertility. So, you know, I think we discussed it multiple times, but I'm going to keep it very short. It's inflammation, you know, and that's what it comes down to. So when you end up having bowel endometriosis, it means that you have advanced disease. So you're going to have significant inflammation, and that's what affects implantation ultimately. It's a long conversation, but something that we'll discuss at length in our
Reproductive Immunology Summit. So this was not planned, but we will have a full, while the Reproductive Immunology Summit is not endometriosis specific, we will have a full hour on endometriosis and inflammatory response, and that will take place October 25th. We have tons of questions here. So I'm gonna ask, we have another question from a surgeon who is saying, and I have something to answer with this, but I'll let the two surgeons answer first. What questions should patients ask to ensure their physician is capable of addressing their endometriosis disease?
You want to take it, Andrea?
No, Gaby, please. You're the speaker.
So we're both the speakers. So for me, it's very important to understand the surgeon's experience, how many cases they've done within the particular area. Do they have a surgeon they work with on a regular basis? How many, what are their complication rates? Because many of us, if we don't have any experience in certain area, what we do, we quote the literature. The literature is different than a person. So every patient have the right to understand their surgeon's personal experience rather than the literature experience. So these are important questions. I would think. I don't know if you want to add anything, Andrea, to this.
I have a question for you, Gaby. What do you think is a acceptable number of surgeries, a minimal number of surgeries that an endometriosis surgeon has to do every month? Like a number you say, like I'm comfortable with a number 10. I think 10 is, we can't say, something crazy, right? Because
no. If we want to be
10 people in the whole country. Yeah.
No, we want to be inclusive. I believe like every surgeon need to have at least 50 cases of endometriosis a year. Now, it's not superficial endometriosis. It's not a small powder burn they resect, they call endometriosis. I feel like 50 cases of advanced endometriosis, which sometimes is parametrial, sometimes colorectal, sometimes bladder. And I believe that will enable them to maintain a certain level of skills. Now, this is the problem that we face every day, because if you saw a powder burn and you removed it, it took you 5 minutes. This is called endometriosis surgery. And if you remove half of her organs, it's called endometriosis surgery. So in the sense, we don't want to get into the pitfall, if we want to look for excellence in care, of the pitfall of, I do 200 endometriosis surgery. No, how many advanced endometriosis surgery do you do? I mean, stage 4 or stage 3, let's say, 50 cases a year would be appropriate to take care of patients, in my opinion. I don't know.
Thank you. I would agree with that number.
So I feel like as a patient, and don't forget I started as a patient, one of the things that's super important when you're searching for a surgeon is you can ask, they can always, a surgeon knows how to answer these questions really, really well. But do they know how to produce the goods? So anybody can say the word excision, but there's actually nothing to qualify excision. But anybody can say, yeah, I know how to do a resection and I'll call in a colorectal, but there's nothing to say that the colorectal has skill and is working. I know Dr. Vidali uses the same colorectal almost all the time, and Dr. Moawad has his team and similar, right? And so it has to be a combination of factors. You need to interview your surgeon and advocate for yourself with all the things Dr. Moawad stated. But you also have to know that somewhere along the line, the surgeon was, I believe, the surgeon had their skills vetted by their peers. And it's not, and I think that there's a new system rising where we can now see that they have put their money where their mouth is and that they really do have these skills. And the system is I Care Better, and it is an endometriosis summit, like big project of ours, but we're hoping a lot more will join. We have another great question coming in, and it's a two-part question. Are there different types of endometriosis on the bowel? So I know my bowel endometriosis not only was nodular, but it was clear. And what are those types of endometriosis? And then the second part of that question is, can you have superficial disease on the bowel?
So definitely superficial disease on the bowel, yes. Sometimes it's a spread superficial disease. Sometimes it's more few foci. And then I believe we still have a lot of misunderstanding about the appearances of endometriosis and the different types of aggression of endometriosis. Because sometimes you do crazy surgery on a patient and after 2 years, they come back with a horrible recurrence. And then sometimes you do one surgery on a patient and she's for life good. She still talks. So we still have a lot of misunderstanding of how the immunologic regulation of a human body will promote the recurrence or decrease the recurrence. And hence, the recurrence rate in the literature is between 7 and 40%. You would think, what is this wide margin? Because there are multiple factors, including surgeon skills, but also including different type or subtypes of endometriosis that we don't understand.
Well,
Yeah,
I would like to comment, on the, and you may agree on that. And I know that those guys, Chaperon and others, have tried to define, because, when you're looking at that, that rectal endometriosis, sometimes it looks like it's kind of on the bowel coming out, right? But in other cases, it's almost like, and I call that invasive adenomyosis.
Mm-hmm.
It's almost like you have severe adenomyosis that's in the back part of the cervix that's coming out, and it's undistinguishable from the uterus almost. You can't even separate it. And then it just invades, kind of like that picture that you showed, that first MRI image that you showed at the beginning of your lecture. So I kind of think that, that's sort of, what the French call that invasive adenomyosis is one version of it. And in my mind, that's probably the worst version, because there's really no surgical plane there. It's just purely, you're cutting through tissue.
Thickened bowel.
Yeah.
Yeah. It's interesting, as a pelvic PT, right before we shut down from COVID, we saw a case of that where it really was that big old nasty disease, like adheres to the cervix, but behind the, and that particular person had been to tons of pelvic PTs, and there's always going to be a limit to what the multidisciplinary team can do. And so sometimes it takes really go to another surgeon who understands and hears your symptoms. We have an interesting question. Somebody's asking, they have a fixed sigmoid from a post excision adhesion. What is a fixed sigmoid and how do you deal with it?
Andrea?
Please, Gaby, I can talk about it, but please, I'd like to hear what you have to say.
Usually after surgery, you have scar tissue. And then scar tissue could be just because your body creates scar tissue after surgery, or your surgery was done in an open fashion, or it could be remaining disease that created, again, an inflammation and scarring. So it could be both. Fixed rectosigmoid, if it's causing symptoms, you need to lyse the adhesion, and if you have endometriosis, you need to excise the endometriosis completely. And then if the bowel is more diseased, you need to do a segmental resection.
Now, Dr.
Can I add to that? Just because people are always convinced that bowel adhesions cause pain. We have to make it very clear that in the great majority of cases, bowel adhesions do not cause pain.
Yes.
Okay, we have seen abdomens which are, everything is stuck to everything, and the patient has zero awareness of it going on. So, I've also seen people that, they have surgery and the doctor cuts a physiological attachment of the sigmoid to the left pelvic sidewall, and they call those adhesions. That's BS, okay?
Yes,
please.
enterolysis, they call it.
It's painful for me to watch that. It's painful for me to read that. So a few adhesions around the bowel without endometriosis should normally be asymptomatic, unless there are signs of obstruction. Just because we do not want people to think that because there's an adhesion here or there, that's the source of their pain. And that leads to more surgery, which is not going to solve it, because a little snip of a little adhesion is not going to solve it.
Now, Dr. Moawad doesn't know this, but for the Endometriosis Summit happening virtually March 6th and 7th, we're going to do a lot of surgical video, because we're going to be sort of a different format this year. We hope that he'll come back with more bowel. But I've been talking to two other doctors who want to do a segment on adhesion barriers and surgery. What do you guys, very off the cuff, not for a full hour, what do you guys think about adhesion barriers? What's your opinion there?
So this
I hate them.
yes, this is mostly voodoo.
I think they're the most useless thing in the world.
Yeah, this is voodoo science. If we think about the pathophysiology of adhesion, is clean surgery, excellent hemostasis, and respecting tissue. If you're going to be bleeding 2 liters, whatever you're going to do, it's going to cause adhesions. The other important thing that I think people misuse the adhesions barrier, because those adhesion barriers that they use, like Surgicel and Snow, these are made for hemostasis. And then if you have bleeding, they create more adhesion rather than prevent adhesion. And there's no FDA product approved for adhesion barrier in minimally invasive surgery. So
I want to also add that Intercede, which is basically, marketed for adhesion prevention, it is not different from Surgicel. It's the same material. Doctors somehow do not know that. They think they're using something different. It's just like it's woven in a different fashion. But Surgicel is Intercede, and it's really like, it's basically a blood loss prevention. Unfortunately, I'm saying this, unfortunately, there's actually literature in myomectomies, which actually, we have to mention that for sake of, for the doctors watching this. There's evidence in myomectomies that using these barriers reduces somewhat the count of adhesions post-operatively. Personally, I think it's bogus science, but there are these studies. And, in my experience, I've never seen these adhesion barriers work. And I know there are some doctors, especially REs, that drape everything beautifully with these barriers. It doesn't work. They don't do anything.
I wonder though, does that, because it's still a foreign object to the body, does that affect inflammation and then also implantation? And I know we'll discuss that further in another webinar, but I wonder while we're here, what your opinion is on that.
Yes, many people who have CT scan, like they come back for pain, they go for a CT scan in the emergency room and they find collection of fluid. And then many people think like, oh, this is an infection, this is an abscess, interventional radiology, go and drain it. And here we go. Now the patient is admitted to the hospital for 3, 4, 5 days with no infection, but they're draining a collection from those. And on those labels, unfortunately, this is what drives me crazy a lot of time. Nobody reads the manual. You want to use something, nobody takes the time to read it. It's listed. These could create inflammation and fluid collection on the label. So,
and by the way, what about, I forgot the name of the little liquid thing that people squirt, the little
I know there's Avicel.
Yeah, that's a
Tisteel.
Yeah, it drives me crazy when I see people.
You know, it's $800
it's absurd.
Yeah.
Plus, there's 2 types of bleeding, right? There's like surgical bleeding, which you got to fix. There's actual vascular bleeding and surgical bleeding. Surgical bleeding is bleeding. You just vas those little areas and that's it. It's just the craziness to chase after these things with all these products, to me, is unthinkable.
Yep.
This is for the surgeons, actually, for the patients,
Well, but I think patients should be aware of what's going into their body. I had no choice, put a lot of mesh in and my hair fell out 6 months later. It was not fun. So we have a great question. If people have bowel endometriosis, are they more likely to have more endometriosis outside of the pelvis? Are those the cases that you see that have diaphragmatic endometriosis, or you feel no correlation? I don't know that I've ever read that in the literature.
I think there's no correlation in my experience. Sometimes you have an isolated nodule on the bowel and the pelvis looks great.
I agree.
Yeah. Excellent. Okay, we have a great question. It'll be our last question, then we'll chat just a little bit. But Dr. Moawad, how is recovery from excision surgery with a bowel shaving different than if somebody were to do a full-on resection?
So with shaving, usually we send the patient the same day home. Even with small disc excision, we send them home. Now, for larger disc, when we take a big piece of the wall or segmental resection, the patient needs to spend 2 nights in the hospital. But if the surgery was done minimally invasive, the recovery is still the same. So we keep the patient in the hospital, not because they tend to have more pain, but because we want to make sure the bowel function resumes and there's no problems with the connection or the anastomosis after surgery. So that's the only reason. But pain-wise, it's the same thing for the patient. Recovery from minimally invasive surgery, 2 to 3 weeks, about 85% of normal. So there is not much longer recovery impact if we had bowel resection or if we have more than, rather than functional bowel symptoms.
I think if your body has been so used to having adapted anatomy for so long, once the advanced surgeon comes in and makes your anatomy nice, then it's a really good time to get physical therapy so that you're learning to use your body on a good pathway instead of just the adapted way. I'll just shove that in there because we should all add that in there.
And let's say it, you know, we recommend physical therapy for somebody who twists their knee and has nothing, you know what I'm saying, who has the most minimal knee surgery, but, you know, it should be recommended for people who have, you know, major pelvic surgery, you know, like, you know, people think it's normal to have knee physical therapy, right? So, I mean, this is, you know, it's so logical and intuitive.
No, this is the thing. We are the technician in the whole process. So we do the surgery, but the approach to endometriosis is comprehensive. You have the diet, the physical therapy, the pain management, the central pain rehabilitation, every single thing come together. Surgery is one portion. You heal, you take away the most pain that is annoying, but still there are a lot of things that needs to be fixed with the physical therapy and then the rehab. It's like you break your leg, they put a rod in it, you go back to the orthopedist, look at the x-ray, say like, oh, it's healed. You cannot go run a marathon. You need to train the muscle back and to train everything back to be able to run again.
Yeah, so what would you like to see in terms of the primary care and the GI? What would you like them to know about bowel endometriosis? Because this isn't something that the guy off the street can treat, but it's very real and it very much exists. What would you like them to know about it?
I believe that every patient who have either non-specific digestive symptoms or the primary, that are related or cyclical to her period needs to be referred to somebody, like as simple as that. Do you have diarrhea? Do you have constipation? Is that worse during your period? Go see your gynecologist. We'll take care of the GI, gastroenterology, you know, aspect of it, but you need to see gynecologists because this is cyclical. It has a pattern.
Yes. And Dr. Vidali, do you have anything to add?
No, I would just like to remind everybody about I Care Better. And, you know, we have new doctors applying all the time. And it's not a private club. I'm sure Dr. Moawad will be part of this club very soon. And so, you know, everybody who is competent is going to be in there. So I think it's something I wanted to just kind of like remind people about. That's all.
We wanted to make it easier for the patient so that when you're looking for somebody who actually answers all your questions like these two amazing guys did, that you can actually find them, right? And that you can kind of rest easy that their skills are up to par. So Dr. Moawad, I hope that you'll join us for some video tutorial for our big endo summit. You're so good at bowel. I hope that you'll do bowel again, maybe.
You don't ask me anymore. I told you, you tell me, like you're gonna present on the endometriosis and I'll do that.
Well, the good thing is that this year, if you had to be recorded, we could accommodate that because, you know, you are so busy. But how many times a year do you teach?
A lot. Like I used to go to, before the Corona, I was in Europe 2 or 3 times a month. But now that Corona, I'm stuck here in one place, but still like every week I have something to do, which is, it's very rewarding for me. And it's more rewarding to teach patients, to be honest with you, because, you know, you can help your patients, but if you teach patients, they can go and find the care they deserve. That's the most important thing.
So Dr. Moawad has recently opened his own practice after many years of being faculty somewhere. And I had a chance today to go through his website a little bit, and it is extremely informational, very much patient friendly. Dr. Moawad, can you tell everybody your website so they can head over there?
It's CEAPS, which is CEAPS.com, which is the Center for Endometriosis and Advanced Pelvic Surgery. And the I, hoping my friend Vidali would be the international center of endometriosis.
Yes. And then we have some ideas that we could do, that we're going to do together. Gaby, please, do you want to tell us how people can find you on Instagram or Facebook also?
Yes, it's also CEAPS at .dc on Facebook and Instagram. And then you can just like Google my name, and then it's easy to find me. I feel like it's very important, and this is what I wanted to do in collaboration with a lot of people is I'm going to start doing patient-directed journal clubs. I'm going to take the opportunity. I'm going to translate the science and the evidence about endometriosis into patient language. So I read the literature. I'll explain it to you in patient terms. This way you can understand, you are up to date on the novel treatment and articles, and you'll be able to ask your doctors better questions and prepare yourself. So get ready, Vidal. You're going to have some work to do.
Ready to roll.
I think that's excellent. Should we, we do that Endo Summit workshop day. We should have one of our workshops in that.
Yep.
That would be great. We'll talk about it.
Yes, definitely.
But
Sally told you. Now that she's so,
I just think it would be great.
Sally doesn't ask. I agree with that. It's a beautiful idea.
There are quite a few surgeons logged on. You have something very special on Facebook. Do you want to tell everybody about your group?
Oh yeah, for the surgeons, we created the AAGL Robotic Special Interest Group. So it's a closed group for surgeons to be able to share their videos, ask questions, ask advice from surgeon, comment on others' video, give positive criticism, help each other as a community of surgeons to empower each other to take better care for our patients. And now we have more than 2,000 surgeons, which is amazing.
Yeah, I think it's awesome. So thank you very much for joining us. I hope everybody goes out and finds you. We have 50 things we could have you for at the summit. We can't wait to see you again. And thanks for being here tonight.
Thank you so much, guys. It's an honor always.
So new to the Endometriosis Summit, if no one has seen it yet, these videos are uploaded into our video library on our website. We will see you August 29th for our virtual 5K. You get a really cool Instagram and Facebook filter of wearing a medal. And perhaps, Dr. Moawad, there might be a surprise coming in the mail for you. And then we will also see you October 24th and 25th for the Reproductive Immunology Summit. And then again, March 6th and 7th. Now, when we begin, I hope to begin at the week after Labor Day. We will go back to our regular Monday nights once we get our Reproductive Immunology Conference tickets launched. So then get ready. Will be lots of live from us. All right.
Thank you, Sally. Thank you, Sally.
Thank you, Sally. Thank you so much.
Bye, Gaby. Thank you.
Take care, everybody. Have a great night.
Thank you. Bye.